Hi, everyone. Welcome to Ask the Egg Whisperer. It is so nice to be here this evening. I really love getting your questions and hearing from you. So if you have a question, go to asktheeggwhisperer.com, send it in, and I'll be here waiting and looking forward to answering your question. So we're going to go ahead and get started. The first question comes from Oleha. And Oleha asked a really great question, and here we go. It says, how can I make sure I am a great surrogate for my 33-year-old sister and her husband? I'm a 36-year-old mother of two, both uncomplicated pregnancies, but both require cesarean deliveries. I've been offering to be a gestational carrier for her since she survived a terrible accident as a teenager. This summer, I again offered to be a gestational carrier for her and her husband, and they accepted. We've completed our psych evaluations and will soon begin the medical bits, sperm and egg collection, embryo creation, and PGA testing. We're hoping to transfer one lucky embryo in February or March. What should I be doing now to help ensure a smooth transfer and a viable pregnancy? Oleha, your sister is so lucky to have you as a huge support person for her. So what you're doing, for those of you who don't know, it's called compassionate surrogacy. So that's when you work with a family member to help you grow your family in this amazing way. So you're literally giving your sister the gift of life. So I can't imagine anything more rewarding that you could give your sister. I'm trying to think if my sister would do this for me, and I can pretty much guarantee you that she would not. She might give me some Botox, but I don't think she'd carry a pregnancy for me. So you're a very special woman, Oleha. So to answer your question, as far as what things you can do to give yourself the highest chance of a successful transfer, I would say, number one, look at your lifestyle and make sure you're as healthy as possible. I'm sure you're already doing this as far as taking a prenatal vitamin. I imagine your doctor already did a preconception panel looking at things like vitamin D, for example, your thyroid, and that they've probably optimized everything. Look at your activity level, how much you're sleeping. If you want to be really picky, you can look at the environmental toxins in your life and see what you can do to reduce the exposure to environmental toxins. Your doctor also has on their checklist doing a saline infusion sonogram. And then at the end of the day, you just got to say, let it go. At the end of the day, you're dealing with your sister's biology and DNA. And we know that when we're using someone else's DNA, things don't necessarily work out the first time. They don't work out the first time, even for our own DNA. And that's called being human. That's the hardest part of giving yourself to somebody else in this way, is that you're used to things working the first time every time. It sounds like you've had 2 uncomplicated pregnancies, you've never had a miscarriage. And when you're helping someone else, you have to talk about all possibilities. Like, what would happen if I transfer, it doesn't work for my sister? If I transfer and I end up having a miscarriage with my sister's embryo, how will that make me feel? And that's what a therapist will talk you through. I imagine you and your sister will already have a super tight bond. And the answer will be, you're going to get through it just like you've gotten through everything else in your life. But I think just having that heart to heart with her about how you're going to handle different results and how that's going to make you feel, and to make sure that it's not going to affect your relationship. The other tip I have for you is, if you guys both have husbands, is make sure that they are all on the same page as well, as far as supporting you through this journey for one another. You guys often hear me talk about implantation testing, tests like the ERA test and receptiva test. In cases like this, I let the embryos do the talking. So depending on how many wonderful embryos your sister is able to create through the IVF process, there are extra tests we sometimes do on surrogates who especially are transferring for the first time. So perhaps talk to the fertility doctor and say, hey, would it make sense to run me through a mock cycle, also known as a dummy cycle, a fake cycle, a rehearsal cycle? These types of cycles have the benefit of making sure you don't have, let's say, allergic reactions to the medications, that you can tolerate them well. You don't have, for example, allergic reaction to the progesterone shot in your butt. That thing can hurt quite a bit. Most people describe that as a painful shot in the butt. So no one ever says, I can't wait for that progesterone shot. So Leah, I hope these tips help you. And I'm really looking forward to hopefully hearing back from you that you guys have a great birth story to come. Okay. So this next question is from Monica. Monica says, hi, Dr. Aimee. Thank you so much for providing all this amazing information. I have a 2-year-old daughter conceived easily and naturally. It was an easy pregnancy, planned C-section because she was breech. We've been having trouble conceiving our second baby. I'm 31. My AMH is 0.7. My FSH 15 follicle count is 8. Healthy semen analysis and the sperm DNA fragmentation test was also normal. The morphology of the sperm is slightly low. I'm taking a Cyberry, Royal Jelly, Ovavite, Ovasitol, DHA, and melatonin. Can you guys repeat after me? Those are a lot of things I said really fast. There was concern for endometriosis due to the low AMH, with all the other extensive labs being normal and a few minor symptoms. So I saw a gynecologist who was concerned for adenomyosis, not endometriosis based on ultrasound and symptoms. I then had an MRI, and there was no evidence of adenomyosis or lesions. There was, however, one small cyst noted, and they likely said it was just a hemorrhagic cyst. But then the gynecologist said, maybe that's an endometrioma. Here's the thing. I would really prefer not to do IVF, and I'm confused as to whether I have endometriosis or not. We've been trying to conceive for 10 months. Do you have any recommendations? Should I change to different supplements? I'm not being recommended surgery rather than IVF with Lupron. Thank you. Okay, Monica, this is the thing. We know your diagnosis. You're a healthy 31-year-old woman with healthy eggs. That's how I think of you. But whenever we have these clinical indicators that tell us that perhaps their egg quality could be an issue, we want to listen to those signals. So when it comes to determining someone's egg quality, the best way to do that is to actually look at the eggs. But I can't give a woman a cup and say, here, give me some eggs, right? I wish it could be that easy. We have these other tests though, right? The follicle count, the FSH, estradiol, AMH. Your levels suggest that perhaps you're someone who has to grow more eggs to hopefully get one good egg out, okay? Doesn't mean you have bad eggs. It just means that in each cohort, you might have less normal eggs just because the whole number of eggs is smaller, okay? You're not in menopause, you're not in perimenopause. It is not around the corner. However, my suggestion to you would be to consider to be as aggressive as you feel comfortable being. And from what I can see, you've done all the diagnostic tests. The only thing perhaps you should consider doing is the T-test, which is the tube test. Maybe get your fallopian tubes checked. You had a C-section. The chance that that can cause scar tissue on your fallopian tubes is really quite small. But getting your fallopian tubes checked would guide you and tell you if it makes sense to keep trying naturally or add IUI versus go right to IVF. If you're a patient of mine, I would say, look, if you don't want to do IVF, let's do this. Let's be aggressive and make sure you're comfortable with that. Maybe give you fertility pills to help you ovulate more than one egg. Since the morphology is low, perhaps add IUI the first time. And then you get 3 months. 3 months and you're up. Because it's always nice to have embryos on ice. Doesn't that sound good? I like how that sounds. So my recommendation for you is be as aggressive as you feel comfortable being. Consider fertility pills with IUI. And maybe after a few months, if not successful, let's start considering IVF, because IVF could potentially fix a fertilization issue if there is one from the morphology. IVF could also help you grow the cohort of 8 follicles that you have. So hopefully you'll get enough embryos for you to have at least one more baby, if not more. I'm kind of biased toward people having as many babies as they want, especially now in the world that we live in. There's nothing more incredible for me to see that the work that I do is helping people bring more love into this world. And there's nothing more better. I know that's not really a phrase, but there's nothing better for me to see than loving people having a loving family and more children. Okay, I was getting too cheesy there, even for me, you guys. Okay, so this next question is, and then Monica, a couple other things. If you're thinking that there could be endometriosis, perhaps add the supplement N-acetylcysteine, and then consider doing the Receptiva test in between your IVF cycle and your transfer if you are considering IVF, if that happens to be something you guys do. Okay, this next question is from Kimberly. Kimberly says, I'm 37 and my husband is 33. We had a natural first pregnancy after 3 months of trying with an emergency C-section delivery, and our son is now 3. We tried for 9 months before conceiving baby 2, which unfortunately ended in an ectopic and a tubal removal in 2019. After this, I went for tests, and I found that I have a very low AMH of 1.91. This is the UK scale, and my husband's sperm looks great from his tests. We did our first egg retrieval, got 7 eggs, 6 mature, 2 fertilized, 1 didn't fertilize, 2 fertilized normally, 2 fertilized abnormally, and 2 didn't fertilize at all. The 2 transfers didn't result in pregnancy. My doctor was pleased with the numbers considering my AMH, except the fertilization rates. He's considering ICSI for the next round. What would your advice be on this? Thank you. So Kimberly, I would say, we know your diagnosis. Your diagnosis is you're 37. With that comes the fact that egg viability is just a little bit lower than, let's say, when you had your 3-year-old son, right? That's kind of, that makes sense. So what can we do to support your egg quality? So look at your lifestyle, make sure you're as healthy as possible, sleeping well, taking your vitamins, eating a well-balanced diet, adding CoQ10, and maybe some other supplements that I talk about if they're available to you, like NAD, stuff like that. The other thing I would consider doing is, even though your husband's sperm looks great from the test, I would say perhaps have him take a multivitamin as well if he isn't already, vitamin D. Everyone seems to be deficient in vitamin D right now. So that's an easy thing for him to do. A multivitamin with vitamin D, and maybe have him take your CoQ10 too. And then I would say, let's consider ICSI. And perhaps not just ICSI. See if your doctor wants to add any other tool. For example, Pixie. I'm not sure if that's available to you. That might be something that can also help. When you have a limited supply of eggs and your egg number is your doctor is right, you want to make sure you're picking the very best sperm cell to inject into the egg. And every clinic and every lab will have their own opinion about how they feel working with sperm is the best for them. So use their guidance, not mine. My advice here is just, informational only, just to give you an opportunity to hear the stuff that other people are asking about so that you can go to your clinic and know what questions to ask in your particular situation, but not to replace the advice of your doctor. So the other thing that I would consider is, with the 2 transfers that didn't result in pregnancy, ask your doctor why they think they didn't result in pregnancy. Ask for the official reports. You guys have all heard of embryo diamonds, but if you haven't, go to embryodiamonds.com and you can read about all the different things you should know about your embryos and go through that with your doctor. The day the embryos were frozen, the implantation rate per embryo. It sounds like you didn't do genetic testing, but perhaps next time you genetically test your embryos. And then if you did, find out which one's abnormal, normal, mosaic, and then find out the sperm on the day of the egg retrieval, because perhaps that day wasn't as good of a sperm day than it could have been. So that's my advice for you. But I still feel like, based on everything that you've shared, you still have a good chance for pregnancy. And I do think that it's worth trying again. So I wish you all the best, and I hope this next cycle works for you as well as transfer. And before I go to the next question, Kimberly, one other bit of advice. With the fact that you had the tube removed in that tubal pregnancy, be sure to look carefully at that one remaining tube. Sometimes you can get a condition called a hydrosalpinx, which is a little bit of fluid in the fallopian tube. That fluid can cause implantation issues. Since you had the 2 embryos that didn't work, it makes sense to perhaps take a look at that fallopian tube before your next transfer. So talk to your doctor a little bit about that as well. Okay, this next question is from Eliza. Eliza says, "Hi, Dr. A, you're such a gift to me, as my husband and I have struggled with fertility for 5 years. We did 2 natural IUIs because I have regular periods and I ovulate predictably, but neither worked. We're both 32 and I'm about to start a mini IVF cycle. I'm very afraid of medication, so that's why we're choosing to do the mini route first. 2 years ago, my AMH was 2.6 and now it's 1.3. And here are the questions. Is this drop alarming for my age? And the answer is, repeat it, right? So if it was 2.6 and 1.3 after 2 years, check it again and really make sure that you are getting an accurate picture of as to what's going on. You can also use your follicle count to kind of also be the tiebreaker. So if your follicle count is closer to 20, then your AMH is probably closer to 2. If your follicle count is closer to 10, then 1.3 is pretty accurate for you. And I would still say that you're in great position to be successful because you have 32-year-old eggs. So I'm not worried based on what you've shared with me so far. You then added here, I suspect I might have endometriosis due to painful periods, but it has not been diagnosed. Also trying to get my vitamin D levels up. What type of mini IVF protocol would you recommend for us? So Eliza, I'll call it the Aimee protocol. So what that means is starting medication cycle day 2. What I tell my patients is when your period starts, think of me, call me, and then I'll see you day 1 or day 2. I use a combination of Femara, also known as letrozole, which is a fertility pill. And I think it's great, especially for people who might have endometriosis. You take 3 to 4 tablets for 5 nights, and then you overlap that with the fertility injections. Lots of different types of injections out there. I'm lying. There really isn't. There's only about 3 different ones, right? So there's Folliston, there's Gonalep, there's Menopur. And you can use a little bit of this, a little bit of that. It's really up to your doctor. And I don't feel too strongly that you should use one over the other. But I would say if your goal is to do a mini IVF cycle, you want to ask your doctor, how many eggs should I expect that you will be retrieving from me from this protocol? So this is the thing. If you went into a mini IVF cycle and you start off with 10 follicles and you only got 2 eggs, that might have been the goal from your doctor's standpoint. Your priority might have been just use a gentler approach, but try to get as many eggs from me and don't try to get a mini number of eggs. So talk about your IVF pyramid at the very start of a mini IVF cycle so you're not surprised by what the outcome is, meaning if you had 10 follicles and you saw 10 follicles and in the end you only got 2 eggs and only 2 follicles got to about 18 millimeters in size or above, you might be really upset, confused, and disappointed as to why more weren't mature. So I've seen this before, and that's why I suggest to people who consider mini IVF is that you have to remember that if you go through that approach of IVF, which is a great approach, which I use all the time, you may be getting less eggs if you have more, okay? And that might be something to clarify with your doctor ahead of time. With this next question, you're asking about something that I'm a little bit passionate about, I mean, I'm pretty passionate about everything, but especially this. I'm reading that some doctors start with birth control first and others line up to the natural cycle. Would you recommend one approach over the other? And a lot of clinics have to use birth control pills because they don't cycle their patients every day of the year like I do. So for me, I prefer not to use birth control pills in most cases. There are some scenarios where I do like to add birth control pills, but for most cases, I don't. So if you're trying to be as natural as possible and don't want to deal with side effects of drugs, maybe taking the birth control pills out is a good idea. But I don't feel strongly that you should avoid them in your case. So the next question is, would you recommend that we do conventional IVF instead? We would like 2 bio kids if possible, and my husband has low morphology and motility, and we have started all your recommended supplements. Okay, Eliza, so with that information, this is the big unknown into the unknown, right? What is our fertilization potential? Like what is our fertilization going to be? That's literally like the unknown. So the more eggs you present to the sperm at the time of embryo creation, the higher the chances that you're going to have enough embryos. You don't have to do IVF again. So if you are a patient of mine, I would say to you, Eliza, what's worrying you about doing IVF and how can I help you? I have patients literally come here every single day for their shot. They come to my house, literally, I have a chair in my house for their trigger shot. I do. I even mix meds on a daily basis for some patients and administer the shot to them. So it really just depends on like what you're worried about, what you're scared about, and see how we can overcome that through things that I just shared with you. And if your clinic isn't able to do things like that, I can tell you that there are a whole bunch of people out there that have gone through IVF. And if you just kind of share this with your friends, I imagine you're going to have like 5 people saying like, I will come over. I will help you. Come over here. I'll mix your shots for you. I would love to help you. So maybe reach out to your community, reach out to your team and see who can step up and help you at this time to see like maybe they can get you to the point where you could potentially do conventional IVF and not do a mini cycle. But when you say conventional, I also think you should do ICSI, Conventional, that term means you're taking a droplet of sperm and putting it over the egg. Since your diagnosis sounds like there's a fertilization issue, what that means to me is if you did conventional IVF, you might wake up the next day and have no embryos. And that's kind of like one of the worst days. We don't like those days. We like the days where like we did it, fertilization rate was average. Average fertilization rate is about 80% fertilized of all the mature eggs, and that's exactly what I would want for you. So talk to your doctor about doing ICSI as part of your IVF plan and protocol. And then if you're still considering mini IVF, no problem, go for it. But make sure you know what your IVF pyramid will look like if you do mini, and your IVF pyramid would look like if you did standard IVF. Okay, this next question is from Jess. Jess says, I'm 41 years old with a normal AMH and FSH levels for my age. I'm about to begin my third IVF cycle, Lupron flare, before treating mild endometriosis with Lupron depot injections. Knowing that I always have a thin lining, the thickest it's ever been is 6.8 millimeters, do you have any recommendations on things to help better chances for my third and final FET? All my past IUIs and IVF transfers have resulted in no implantation. Previously, we've taken estrogen pills, estrogen patches, Viagra suppositories. I've consumed more pomegranate juice than I ever thought I would, but all to no avail. I have Hashimoto's as well as psoriasis and eczema. Knowing this is my last chance at a pregnancy, I am all ears for other suggestions to thicken my lining so that after my endometriosis is treated, I have as healthy and welcoming a uterus as possible. Okay, Jess. So there are different ways of getting the lining thicker. And I imagine your doctor's explored all of these ways. So number one, ask your doctor, how thick did my lining get on the trigger shot day before my egg retrieval? Use that as information that can guide you. If your lining thickness was the best ever when you were actually taking stimulation medications, you have one approach you can consider using. And that's called a stimulated frozen embryo transfer cycle, right? So that's one option. The next thing is look at the different types of estrogen that you were doing, right? So there's pills, there's patches, and there's shots. So the estrogen shot is one way of getting a very nice, thick, plush. I feel like I'm talking about carpet. I am not. I'm talking about the lining of your uterus landing pad for an embryo. So if you haven't considered the estrogen shot yet, perhaps try that. Sounds like you probably have. Whenever you start pulling out the Viagra suppositories, I get a sense that your doctor knows exactly what they are doing and they're offering you everything. So a couple other things that you might want to consider doing, and you're going to be like, has she lost her mind? I promise you, not yet. So a couple things in the literature. Number one, HBOT stands for hyperbaric oxygen therapy. I've used it before, and I've seen in some patients, my sample size is small, we're talking about less than 10 patients, who have problems thickening their lining. There is an HBOT, hyperbaric oxygen tank, protocol for people who have a thin lining. So that's one interesting thing that you might want to consider doing. The other thing is, I know I talk about HGH. You would think that like, you know, I don't know, I have some sort of relationship with the company that makes it, and believe it or not, well, you should believe it. I don't. HGH has also been shown in scientific studies to maybe help with the lining as well. The other thing, I don't have an experience with this, but I know other doctors do and they use it, and they have had good experiences with helping women who have a thin lining, and that's using something called PRP or platelet-rich plasma. So they draw your blood, they concentrate the platelet-rich plasma, and then they inject it, they infuse it into the lining of the uterus. And I've heard of some cases where the lining gets thicker. I have not personally had an experience with that myself. I could go on and on with all the different things, but hopefully some of these tips will help you. And then you have the supplements like vitamin E, L-arginine, aspirin that might help as well. Okay, this next question is from Mindy. Mindy says, I'm going to be 37 in April. My AMH is 1.48. This was in 2017, 0.83 in 2018, 0.61 in February of 2020, and 0.56 in June of 2020. HSG normal, lining always 8+ at time of transfers. TPO antibody 239, TSH controlled 1.91 with Synthroid 50 micrograms. First IVF canceled, didn't stimulate. Second IVF, 6 eggs, 4 fertilized, 3 blasts, no PGT, transferred 2 fresh, no pregnancy. Third IVF, 6 eggs, 3 fertilized, 2 blasts, no PGT, both cycles with femera and stims, ERA receptive 126 hours, BCL6 positive, did Lupron. That sounds a lot better than Lupron, I guess, to me at least right now. I transferred the remaining embryos over the months and still no pregnancies. Switched clinics, had hysteroscopy, laparoscopy, removed an intrauterine polyp, 3 cysts on the right tube, 1 cyst on the left tube, endometriosis inside and outside of both ovaries, and I was labeled as stage 2 mild endometriosis. Now I'm on IVF cycle 4, estrogen priming, Lupron, Follistim, Menopur, Ovidrel, trigger shot, estradiol, 1,469 at trigger, 9 retrieved, 6 fertilized, 3 blasts, 5 AA, 5 AB, both hatched, and a 4 BC. I did PGT and none were genetically normal. So Mindy is asking, is there anything I could have done differently? Is it time for a donor? Mindy, I'm sorry you've had this experience. You're only 37. You're a young, fertile woman to me. And I can only imagine how hard it's been to go through all of these cycles and still not be successful. And then to find out when you're doing the PGT that none of them came back normal. Before you discard your embryos, I would ask for the official reports and look at the fine print and see if any of your embryos were labeled as Mosaic. And also ask them if they disclose mosaicism to you. You would think that most clinics will be honest and transparent and will let you know if any of the embryos are Mosaic. However, there are some clinics that tell the genetic testing company, don't tell me if any of the embryos are Mosaic, just label them as abnormal. And there is a chance, and it's not a super low chance, but there is a chance that a Mosaic embryo can turn into a healthy, beautiful pregnancy. So that's why it's important for me to educate you guys about what this means. And that's why the M of embryo diamonds refers to mosaicism. So make sure you ask your clinic that. You've already been through 4 cycles. You've been through so much. If you still have one more cycle in you and you haven't done, for example, HGH priming, taken my supplements as if they're mine, like the True Niagen with NAD in it and high dose CoQ10 with pterostilbene, for example, it still might make sense to do one more cycle because you made such beautiful blasts. I just wish that I could say, go ahead and try naturally, but it sounds like there could be some tubal issues, some anatomic issues with embryo transport because of the endometriosis they saw in the fallopian tubes. So my suggestion is this: before you make a decision about what to do next, go back and consider doing an HSG. And if you haven't looked at the official reports, especially at the sperm reports, do that and maybe consider doing a sperm DNA fragmentation test if you haven't already. I imagine your doctor would have told you if the chromosomal issues in the embryos were inherited, like if there was some sort of structural rearrangement that you and your husband carried. It sounds like you probably don't, but ask that question if you haven't already. Just simply say, does it make sense for me and my husband to get a chromosome analysis or not? So from here, you have to answer the question, am I ready to just move on to something that will give me the highest chance for pregnancy? Or do I feel like I should try one more time before I do that? But it's so nice to talk about all the possibilities and just to say and breathe, I'm going to be a mother one way or another. Because the fact that you're even thinking about an egg donor means to me that it truly will happen, because I feel like you have everything you need for it to happen. Sounds like you have a beautiful uterus with a healthy lining. So I would say, if you're a patient of mine and you came to me for a second opinion, I would say, I imagine your eggs will be sparkling and talking to me and glimmering and say, Aimee, give me one more chance. But at the same time, if you feel like going through another cycle that didn't work, or to find out that the embryos didn't have normal chromosomes would be just too heartbreaking to be able to move on to egg donation, then perhaps just move on to egg donation now, because it is a wonderful way to build your family. And especially because you're young, especially, or in the case of you wanting to have more than one baby, it will then allow you to hopefully have more embryos from the same donor so that you can have the family size that perhaps you wanted from the beginning, which could potentially be more than one baby. Okay, so this next question comes from Jenny. And Jenny says this: after 4 pregnancy losses, I found out that I have a balanced translocation. All of their testing they did on me looked great. First round of IVF resulted in 12 embryos after testing. Only 1 was healthy, 7 had the translocation, and 4 with other chromosomal abnormalities. Unfortunately, the transfer of the healthy embryo was unsuccessful. What can I do to have more healthy embryos in my second round? My RE suggested estrogen priming to help with egg quality, and I've added CoQ10 and melatonin. So this is the thing, Jenny. When you have a balanced translocation, there literally is, I mean, I'm not going to say nothing you can do, but it's just in your DNA. And I've had these experiences with other patients, and to make you think that it's something in your control, I would say it just isn't. I think the best thing is that you make blastocysts and you had 12. So from my standpoint, this is not an egg quality issue that one came back healthy, because if you have 7 that have the translocation, you actually are a young woman that has good egg quality. The fact that the translocation was there doesn't make me think you don't have good egg quality. Having 4 embryos out of 12 that don't have normal chromosomes is actually quite fantastic. So I would celebrate that aspect that you got one. And I would say, changing the protocol, if your doctor thinks that makes sense, go for it. But I think any protocol that gives you 12 blastocysts, even though one was unaffected and had normal chromosomes, that to me is a successful cycle when you have a balanced translocation. So I would say that there are, and I'm sure that you probably are connected with, Facebook groups for people who have balanced translocations. And I imagine if you even on Instagram put in #balanced translocation, you're going to find other people that will support you as you're going through this journey, and they're going to share some of the experiences that I've had. And I think a lot of my patients are in those groups as well. So thank you for reaching out and asking this really good question that so many people I imagine have who have a balanced translocation. This next question is from Sienna. Hi, Dr. Aimee. Is it possible for the stimulation medications to affect your egg quality and lead to less good embryos? Sienna, that's a really great question. I mean, you hear this concept of frying your eggs or overcooking them or undercooking them. And at the end of the day, yeah, I mean, I think that, the protocol does matter. Sometimes I wonder when a patient has like 3 follicles and they're given like 900 units of medication a day, and that just doesn't make sense to me. It just feels like you're wasting money, and I don't know that it really affects eggs, but maybe it could. And then if you're overstimulated, I'm not really sure that we know 100% that can affect egg quality. But I would say if you have an embryo quality issue, you have to look at age, genetics, and environment of both the egg and the sperm and see what you can do to improve things on both sides. And looking at the medication protocol makes perfect sense, and talking to your doctor about all the stuff that I always talk about, like the embryo diamonds, and learn everything about those, about your cycle as possible, about the protocol, why they chose it, what they were expecting as far as your IVF pyramid, and then see what they think you should do next. But as far as the medications causing them to be less good, I think there might be scenarios where that's possible. And one scenario that I can think of is, you guys know what I'm going to say, is the use of birth control. I'm just kidding. I mean, I don't think birth control decreases embryo quality. I just think it might result in less good mature eggs, or less mature eggs at the end of the day. Okay, this next question is from Samantha. And Samantha says, hi, Dr. Aimee. Thank you for taking my question and all that you do. My husband and I have been trying to conceive for about 3 years. I've been taking OPKs for 1 year and ovulating normally and timing intercourse. We both have full genetic screening, husband normal, but I found out that I'm a premutation carrier for Fragile X. After speaking with a genetic counselor, she said I only have a 1% chance of passing it on, but should get my AMH tested yearly to screen for DOR. My AMH is 3.8, estradiol 36, FSH 4.8, prolactin 18, TSH 1.6. I'm 32. My husband's sperm count, motility, morphology, all normal. My RE told us we could get pregnant naturally, but given how long we've tried, it's less than 2% chance per cycle, and IUI would be 12 to 15%. She suggested IVF with PGTM testing given my Fragile X, and we potentially would want a second child. My question is, what protocol would you put me on, and would you suggest PGTM testing of our embryos? Awesome. So Samantha, it is nice to have embryos on ice. I just wanted an opportunity to say that. I know that sounds super cheesy, but I think you are doing the right thing. As far as doing PGTM, I would say that's a very personal decision and choice. Talking to a genetic counselor is exactly what I would do, and that's exactly what you did. And if you choose to minimize your risk of passing on the Fragile X mutation through PGTM, I would do that too. 1% is still a 1%. And so you can reduce that to 0% by doing PGTM. For those of you guys who are like, what is this alphabet soup that she's talking about? Let me break it down. When you look at the genetics of an embryo, most people think, oh, you can see everything. The truth is we can't. We can only look at the chromosomes. That's it. We can't look at the genes unless we know what gene to look for. So what PGTM means, it's basically meaning looking for the Fragile X mutation in the embryo. So the way we do that is you kind of have to know that you carry the mutation before you make the embryos. And then you also can check the chromosomes too. So it's kind of like looking at the chromosomes and this one gene. One day, I hope it's when I'm alive. You know, you're going to be at like Safeway or, you know, whatever the grocery store you go to, you just got this scanner and you just go scan over the embryo, beep, and you're going to be like normal chromosomes, normal genes. I know that that's probably just wishful thinking from my standpoint. But until that time, I just have to educate people that just because an embryo has normal chromosomes doesn't mean you look at everything. It doesn't mean you ruled out all the genes. It doesn't mean you ruled out birth defects. It doesn't mean you ruled out autism. The list goes on and on and on and on and on. So that's why Samantha's question is really important for me to answer here today, because it helps you guys learn the power of what I call the murky crystal ball. And that is genetic testing of embryos, because it is not perfect and it doesn't look at everything, but it can predict certain things. And in Samantha's case, it can predict whether her embryos will have the Fragile X gene or not. For those of you who are like, Fragile X, that sounds like something that's fragile, yes. And why would we not want to pass it on? Well, this is the thing. Fragile X syndrome is the most common genetic reason for autism. So that's why it can be important for people to basically stop it from being passed on in their family tree. And the reason why her doctor brought up DOR, which is decreased ovarian reserve, and checking her AMH frequently is it can also lead to early menopause. So she's doing all the right things, asking all the right questions. And that's why, guys, not to digress, the why of the Tushy method is your genetics. See how powerful it is that Samantha knew this at her young age, right? Like, that's pretty powerful. If she had found out later or didn't find out at all, she might have been pretty upset, especially if she found out later, that this was just a simple test she could have done at the beginning of her family making journey, baby making journey, I should say, that could have prevented heartache. So anyways, back to your question is, as far as protocol and what I would put you on, with an AMH of 3.8, I actually think you could be someone who could be on birth control pills. It sounds like you have a lot of follicles, so you want to make sure that your doctor is addressing this one question that you're going to ask them, and that is, how are you going to prevent me from getting severe OHSS? And every doctor has a plan, but you just want to make sure that you hear that plan so you feel really comfortable with the protocol. I would probably start you, depending on your body size, given that you're 32 years old with probably a lot of follicles, I would probably say something like 150 units of FSH and maybe 150 units of something like Menopur. That's 2 vials of it. And then maybe bring you in after 3 or 4 days to see where your estrogen levels are, and then titrate the dose accordingly. Maybe keep you on the same dose or bringing you down. But that's a pretty standard protocol that I would use in someone at your age. And I would use an antagonist protocol and possibly use a Lupron trigger, maybe with low dose HCG. It just kind of depends on how you're feeling and how many eggs we get to grow. Okay, guys, this next question is from Jennifer. Jennifer says, hi, Dr. Aimee. I was diagnosed with POF. So that's premature ovarian failure. I hate the word failure. So let's just call it premature ovarian insufficiency, or my ovaries just decided to take a break when I was 30. That's when Jennifer says this happened. We worked with an egg donor to have 1 child in 2014 and used a frozen embryo through the first donation, then became pregnant again in 2018. Tragically, our infant daughter died 1 week after a traumatic birth, and I had a placental abruption. Our donor kindly donated again in 2019. We have 2 embryos remaining after 2 chemical pregnancies that ended in early miscarriages in 2020. I've since undergone uterine and genetic screening, and nothing looks amiss, and our embryos were normal. What steps can I do to make sure I'm doing all I can under the circumstances to become pregnant? Are there things that can help prepare the lining or assist with a successful implantation? My fertility journey has been long and difficult. I'd appreciate your advice on how to look ahead to the future. Jennifer, it really has been long and difficult, and I'm really sorry. Very, very sorry. So here are my suggestions and thoughts. When I hear placental abruption, I always want to ask, are there any risk factors for that? Okay, risk factors, cocaine, right? No, you're not doing crack, right? That's not happening. But there is another risk factor that's pretty common in fertility patients, and that is adenomyosis and endometriosis. So let's learn from that pregnancy and ask your doctor, have you ruled out adenomyosis and or endometriosis? Could that be playing a role in what is happening? And then when I also think of a placental abruption and some sort of emergency delivery, I think, was there also possibility that there could have been a mild infection? So I'm thinking about endometritis, and I'm also thinking about, did somehow your fallopian tubes get affected and blocked? And is that why you had the biochemical pregnancies? Did perhaps the embryos get affected or maybe go up into the tube? Or was there fluid in the tube that affected implantation? So if you were a patient of mine, I would do this. Consider doing a mock cycle for the ERA and Receptiva DX test. I'm not super, I'm not stuck on you having the ERA test, but I feel like the Receptiva DX test would make sense. Do a hysteroscopy, do an HSG, and take a look at all the things that I mentioned. And then I would say, depending on what you learn, even if everything was negative, perhaps consider a protocol where you're maybe taking Lupron for 1 month with Femera and then transfer. So just 1 month of PrEP before your transfer cycle. But I'm going to warn you that double Lupron does come with a survival guide. There are some tips that you need to read about before anybody takes it, because this drug can be quite awful. It can put you in quite the mood, and it can make you snarky for at least 30 days until the medication's out of your system. So I'm just warning you a little bit about that right now. So I hope these little tidbits that I just shared with you helped, even in the smallest way. I really hope that they did. Okay, this next question comes from Anna Marie. Anna Marie says, I'm 38 and trying to conceive. Earlier this year, my husband's 36. We only want 1 child. After 2 miscarriages, 1 we tested and was confirmed trisomy. We decided to thaw eggs. I froze at 35. I also have PCOS. My AMH is 9. FSH 6, prolactin 6, total testosterone 42. I have a normal body size. My BMI is 20. We had 16 eggs survive the thaw. 13 fertilized, 10 made it to day 3. We were looking good, but only 2 made it to day 6. 5 AB and 4 BB. We did PGS testing and both came back abnormal. We're looking now to do IVF. My doctor said she changed up the protocol for my previous egg retrieval, which was gonal F, Menopur, Cetrotide, HCG trigger. This time she's introducing Lupron for suppression and Omnitrope. So here are the questions. Do I think these are the right adjustments? Is there any alternate protocol you'd recommend? So Anna Marie, here's the deal. You told me that your AMH is really high. My concern is about severe OHSS. So when you use Lupron as part of the suppression, you can't use Lupron as part of the trigger. You're forced to use HCG. So you have to talk to your doctor about, what are you going to do to keep me safe? And is it smart? I mean, don't be a smart aleck like that. Don't be snarky. Snarky is my word of the day, if you can't tell. Anyway, so that's why I think it is really important to ask your doctor why the choice of Lupron if you're at higher risk for OHSS. But let me see if there's anything else that I would add to this. The other thing would be to just consider my egg quality support regimen, right? So consider adding HGH to your protocol, all the supplements that I'm always talking about, like NAD, pterostilbene, CoQ10. With the PCOS, it sounds like you're well balanced with your hormones. Maybe adding something like Ovasitol could help. If your A1C is super, super low, I'm not sure that it could really help by that much, but your total testosterone is a little bit on the higher side. I mean, it's definitely, it's not outside the normal range by any means, but maybe adding Ovasitol could potentially help with egg quality. I'm just throwing that out there as a suggestion. So I would say you're doing all the right things. I think you definitely still have a good chance of having a normal embryo in another cycle. And the fact that you made blastocysts is a really good sign. And then one last thing is look at the sperm quality on the day of the egg thaw. I have an article and it's the egg thawing party. It's on my website. And the reason why I did that is I feel like sometimes things are not missed intentionally, but there's certain like checks and balances that people don't know that they could put into place before eggs are thawed. And one of them is this: please don't thaw my eggs unless the sperm is sparkling. Like literally, you can tell your doctor to put that on the lab order, right? Because the person in the lab doesn't know that that's a bad sperm day for your husband. But what if it is? And they just thawed the only eggs that you have frozen on a bad sperm day, right? So sometimes I tell the lab, I say, hey, call me, and then I'll give you permission to thaw the eggs because I get kind of a little snarky about stuff like this. I want everything to be absolutely perfect for every single patient that I am so lucky to see and take care of. So that's one of the things that I do. So ask your doctor if the sperm was sparkling. Ask them if adding something like Pixie would help. Ask them about HGH. Think through all the supplements you're taking and keep doing all the fabulous things that you're doing, Anna Marie. Okay, this next question is from Janice. Janice says, Dear Dr. Aimee, I recently went through 3 failed IUIs and 2 failed IVFs. Tushy and sperm have been checked. I'm 37 and my diagnosis is low diminished reserve with an AMH of 0.7. First round of IVF, 13 eggs, 10 fertilized, 3 low-grade blastocysts, and none were PGS normal. Second round, 16 eggs, 11 fertilized, 2 low-grade blastocysts, none were PGS normal either. My doctor says it's an egg quality issue. My husband and I are not in a financial position to do another round of IVF. Do you have any advice you can offer on how I may increase my chances of a natural pregnancy? If I do have the opportunity to do a third IVF, would you suggest I do something differently so that I can get PGS normal embryos? Do you think ICSI can increase the chance of having abnormal embryos and currently taking CoQ10, pterostilbene, and NAD? Janice, good job. The other thing I would consider adding is HGH. I even add it in my IUI cycle. I know you've already done 3 IUIs. As you're figuring out what you need to do next or what you're going to do next, keep trying. I know you're like, huh? Like, why would I even expect that I'm going to get pregnant while I'm trying naturally? And I think that you would expect that because it sounds like you and your husband love each other. And when 2 people love each other, miracles can happen. Of course, I'm not trying to exclude people that are not in a heterosexual relationship. So please don't take any offense to how I'm talking at all. If you can't relate to Janice's question, I don't mean to exclude anybody when I'm answering my questions. But what I would do in a case like yours, Janice, if you're a patient of mine, is I would say this: Janice, I'm going to order you some Femara. You're going to take 4 tablets at night for 5 nights, and you guys are going to try naturally. You're going to take progesterone 3 days after ovulation until your pregnancy test, which is going to be 14 days after your positive OPK, and let's see what happens. You're going to continue all your fabulous supplements. You're going to do your acupuncture. You're going to build your fertility team around yourself. And you're going to continue to have hope, which is have only positive and practical expectations. And then we're going to give ourselves a time. We're going to say in 2 to 3 months from now, we're going to look at your FSH estradiol, your follicle count, and your AMH. And we're going to ask ourselves, does it make sense to try again with your own eggs? Does it make sense to put you through another IVF cycle? And if the answer is yes, we're going to do it. If the answer is no, we're going to start considering other options because it is so expensive to have a baby. And I do want you to be a mother one way or another. But it doesn't have to be with your own eggs. If your doctor is saying that the egg quality is really, really low, you have to say at some point it doesn't make sense to keep trying. But as long as you're making blastocysts, from my standpoint, it does make sense to keep trying if you're okay doing so and if financially it makes sense. If financially it doesn't make sense, then there are other things that you can do. Obviously trying naturally is free. But the other things that you can consider doing that are not as expensive would be embryo donation. And then you can save money for egg donation because there's no such thing as an egg donor emergency. This next question is from Carrie. Carrie says, I'm 33 and my husband's 35. We have a 3-year-old daughter who was conceived on our first month trying. We've been trying to conceive for 18 months now. My husband's sperm is normal and I've had a hysteroscopy, pelvic ultrasound, which were all normal. My AMH is on the low side and I have 14 follicles. Would IUI be a waste of time? Should we go straight to IVF? My consultant does not feel that I need my tubes tested as I conceived my daughter the first time. All blood work was normal and I have regular periods. Is there anything else you would suggest? Okay, so here's the thing, Carrie. get your tubes checked. Just because you have a daughter doesn't mean that both tubes are open, right? It just means that one tube is open. And it's not like right, left, right, left, right, left. You can be ovulating from your block side every month for a year. I mean, that probably doesn't happen, but it is possible. And I have patients that come to me, yeah, Dr. Aimee, my right tube is blocked. And I ovulate on my right tube every even month. And I'm like, no, no, no. That is not how it works. And they're like, what? I'm like, I know. What you're saying makes complete logical sense, but the reality is that is not how it works with our fallopian tubes and the side that we ovulate on. It's literally flip, 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 flip of a coin, 50-50. And it could be right side, it could be heads every single time for a month. I mean, for a year. God, I wish we could ovulate every day of the month. Wouldn't that be nice to be able to try every single day of the month? So, Carrie, my point is this: do get a tube test. And what your doctor says makes it, I mean, he checked a sperm test. So it makes it like you would say, well, you check my husband's sperm and we have a daughter. Like, wouldn't you check my fallopian tubes? So then based on that, if you guys are now trying for 18 months, maybe consider a little whiff of fertility pills, help you ovulate more than one egg, recruit an extra egg and see if that helps. Maybe add IUI. And then depending on how many more kids you want, especially if, with 14 follicles, you're doing mighty fine there with your egg count. The only concern with doing IVF would be, are you okay having unused embryos that you may not need? But I would say if in the next 6 months to a year, you guys have not conceived naturally with ovulation induction, or IUI, it would make sense to try IVF. And then also look at the genetic screens and make sure you've done enough. You would be surprised about the number of structural rearrangements that I catch in my patients every single year. I think just this year alone, I picked up 3 or 4 cases where someone had an abnormal chromosome analysis. So that's another simple test that you can do. The likelihood of you having that is going to be probably, 1%, 1 to 2%, very, very low. But it's a simple test that you can get done and maybe see if your doctor would consider doing that for you or your husband. Okay, this next question comes from Canada. Here we go. This is Alexandra. And Alexandra says, I'm 32 years old, living in Canada. My husband and I conceived naturally in July 2020 after 1 real month of trying. I unfortunately had a natural miscarriage in September at 7 weeks, 2 days, and have been on a journey to recovery and arming myself with knowledge ever since. So that's pretty powerful, you guys. So since September, she miscarried and she is recovering, and this is January. And I can tell you everyone's journey or the length of time that it takes them to recover is different. There's some people that don't ever recover. The hole in their heart stays there for decades. There are people that put, I've had patients that put tattoos to commemorate a pregnancy that ends at 7 weeks. So everyone's grief and how they experience it is different. And that's why it's so important for me to honor and recognize every single pregnancy, even if it's a biochemical pregnancy with my patient. Because in that moment, she believed that she was going to be a mother. And then to have it taken away is extremely cruel. So thank you for sharing that little bit about yourself, Alexandra. My results so far, AFC is 22. All other hormones look good. 1 posterior subserosal fibroid measuring 2.5 centimeters. No one seems to be worried about it. My husband's results are as follows. Count of 8.8 million, which we've been told is on the lower side, but could have been due to the length of time since we had intercourse of only 2 days. Good motility. Shape was also on the lower side. Of 1% normally shaped. DNA fragmentation was normal. Since the miscarriage, we've tried again for the last 2 months without a positive pregnancy after speaking to a few fertility doctors. The recommendation ranges from going on a low dose of fertility drugs and IUI to continuing to try naturally without any intervention for a few more months without taking a more aggressive form of action. If you are looking at my history and our collective results, what would you recommend at this stage? Are my husband's sperm results alarming to you? And if so, should we repeat the analysis again? So Alexandra, yes, it's really hard to get pregnant when the total mobile count is 8.8 million. You're making an assumption that that was just due to the fact that you had a short window of abstinence, but that assumption needs to be proven. The morphology being on the lower side may cause a fertilization issue. Obviously, you guys got pregnant in July, but we know things can change with sperm. And we know even if the morphology is low, it does not mean you cannot get pregnant naturally at home. It just means that it might take longer to achieve that. So go to ballsmethod.com. You've already done the B part, which is the background genetics, looking at sperm DNA fragmentation, but I would also look at chromosome analysis for him, and maybe even you. I would look at whether he has a varicocele or not. Maybe he has one that has grown since the summertime and you just don't know it. So seeing a urologist would be able to determine that. Check his testosterone level and see if it's low. There are steroids a guy can take, like Clomid, Arimidex, Gonal-F, HCG shots, for example, that can increase the sperm counts. Look at the supplements that he's taking and make sure that he's taking something like Conception XR from Theralogics. And for those of you guys who want to, you can go to that website, theralogics.com, and put in the PRC code, all caps Tushy, for the PRC price for their products. And then look at his lifestyle, make sure he's cutting out anything that's fun. I do want him to find joy in each day. Believe me, I do. But no marijuana, no tobacco, no chewing tobacco, no vaping, no whiskey. That's what my mom calls whiskey. It's very annoying to be her daughter because she's making up words. And then growing up in that household, I thought those were the words. Like I thought election was erection my whole life until I left home. No, I'm just kidding. I didn't think that. Maybe until I was 10. Okay, so Alexandra, I think that you have a great chance of pregnancy. I think that after you've ruled everything out, it would make sense to maybe consider IUI. But if the sperm counts stay where they are, I would say to achieve your goals, I'm not sure what they are as far as the family size that you want, I think it would make sense to consider IVF sooner than later. Remember, it's always nice to have embryos on ice. And if you guys are so lucky to get pregnant naturally or with IUI, freeze that sperm. Believe me. I have patients who come in 8-10 years after they had a struggle and there was male factor infertility and the sperm is lower. And I'm just like, I wish we had frozen sperm when I met you guys 10 years ago. Because it's so easy to freeze sperm, right? 1 cup, here you go, freeze it, $150, right? An egg, freezing each egg. I mean, each egg is probably like $3,000 per egg if you kind of like look at all the money and the medications and the procedures and all that kind of stuff you have to do. So unfair. Okay, this next question is from Mel. Mel says, I'm doing 60 days of Lupron prior to my FET because of an elevated BCL6 score from the Receptiva DX test. Normally, it seems people take their last Lupron injection, wait 30 days, and start FET prep. However, I'm supposed to start estrogen 1 week after my second Lupron injection. With that timeline, I would transfer before the Lupron is out of my system. Lupron Depo Lupron says not to take it while pregnant and says it can cause spontaneous abortion. I'm worried that if I'm still in the 30-day window of my second Lupron injection when I do my transfer, it will cause the transfer to fail. Would you be comfortable with this timeline? If not, would you be comfortable taking estrogen and progesterone during the 30-day window, but transferring on day 31? Or would you want more of a break between clearing the Lupron from my system and doing the transfer? Thank you for all you do. It gives us peace of mind. So Mel, I've actually seen it all. There are some clinics more internationally that I've seen, they actually give a shot of Lupron. That's to prevent cyst formation throughout the FET cycle. And you take the estrogen and progesterone and then transfer once, like the 31st day. I've seen it. It's worked just fine. The reason why Lupron could cause a spontaneous abortion is because you're not able to make progesterone from an ovulation if you happen to get pregnant, right? It shuts that down. But guess what? Mel, you're going to take those hormones. So it's really important that your priorities are your doctor's priorities. So if you feel like, God, I'm just going to be so stressed out and worried and nervous by this protocol, guess what? Just say, hey guys, can I just start my estrogen on that 31st day and just transfer 3 to 5 weeks later? I'm going to feel more comfortable with that. See how easy that is? And if they say no, I really doubt they'll say no. Just say, you guys, this is what I'm comfortable doing. Make it happen. So I doubt you're going to get much pushback, but that is a way of doing things without harming your chances because you are going to be supplementing with estrogen and progesterone to support a growing pregnancy. This next question comes from Kate. Kate says, thank you for being such a sparkle in the fertility community. I'm 32 years old. My husband and I have been trying to conceive. Do you guys see all the sparkling eggs back here? This is what I got for Christmas this year. Among other things like my Apple Watch, but this is the sparkling egg that I got. And then this was supposed to be a sparkling egg, but I think he kind of missed the boat on this one. And I was like, honey, it's a blue testicle, a blue ball. Oh, God, I crack myself up. It's fertility doctor humor over here. I really should be keeping my day job, literally. Okay, So back to Kate's question. I have low AMH, varies between 0.298 and 0.77, and my FSH is 7.5. For my first IVF cycle, my clinic started me on birth control for 6 weeks. The week before starting stims, my estradiol was 99. It was 67.5 2 months prior on day 3. They did the following protocol: twice a day of microdose Lupron, then 150 of gonal, 75 of menopur. After 8 days of stim, I had 2 leading follicles measuring 18 and 21, and 6 that were in the teens or lower. They converted me to an IUI due to poor response. Unfortunately, my cycle was canceled after I spontaneously dissected my vertebral artery. I'm healed and ready to start my second cycle. I was wondering what protocol you would use to mature more eggs at the same time. Could the birth control pill have contributed to this? Please help me grow these follicles. Kate, I'm not sure what caused you to dissect your vertebral artery. I'm sure that you've asked them to rule out every possible reason, including genetic reasons, as to why that could have happened. I'm glad you're healed and you're clearly resilient and very, very strong, because you're just getting back on that horse and you're just like, I'm going to do this. So I'm proud of you. I mean, I'm kind of not just proud, I'm kind of amazed at people like you. I'm amazed at everybody that sends me in a question, but especially someone who's like risking their life and limb for this. So not that I think that you're doing that, but you know what I mean. So to answer your question, I would say no to the birth control pills. I would try and use as natural approach as possible. I would ask your doctor if it makes sense for you to consider a mini IVF protocol rather than standard doses of medications like gonal F and menopur. Perhaps have the goal be to get 2 to 4 eggs. The thing is, your AMH is between 0.2 and 0.7. So that tells me getting a few mature eggs is actually the potential number of eggs that you should expect. Given the fact that you're 32 years old, I would say you could get a blastocyst from each egg that you're making. And you could get 1 to even 3 blastocysts if you're 32, even if your follicle count is less than 7. I see it all the time. I've seen it before. And I would say in a case like yours, I wouldn't cancel a cycle if you have 2 mature eggs and a few that are in the teens. I would say go for it and take it to retrieval. So that's my recommendation for you. No birth control pills, natural cycle, gentle approach, lots of TLC, and even if you get 3 to 5 mature eggs, that to me would be a really successful, nice cycle for you. Okay, this last question comes from Sarah, and Sarah says this: hi, thanks for all the information you share. I had a successful IUI, the third with Clomid and Trigger in 2019, uneventful pregnancy. Actually, I lied. This is not the last question. I'm going to keep going. Had my son in July, my numbers weren't good, so my IUI success was surprising to me. AMH 0.9, FSH 15, 1 tube closed on the dye test. Now I have a 6-month-old and want another. Would you try IUI again or go straight to IVF? I'm 37 using donor sperm. Also, what is the balance between waiting for my body to recover and not waiting too long? As I'm 37 with poor numbers, when would you go in the clinic to start again? Okay, so with an FSH of 15, being that you're 37 years old, if you're comfortable going right to IVF, I would do that. I would. I mean, the thing is this, with 1 tube that's open and 1 tube that's not, it's much harder to get pregnant. And if you stimulate your ovaries, I've seen this time and time again, it's so frustrating. I'm like, try and swallow the pills on the right side of your mouth and maybe the right tube will, no, that's not how the ovaries work. Or give yourself the trigger shot over here and the egg will go to the left. No, that's not how things work either. So by stimulating your cohort of eggs and doing IVF and creating an embryo, then putting in the uterus, that's kind of what I would recommend to someone who really wants another baby, is 37 years old, has a lower AMH, a higher FSH, and 1 remaining tube. So that's my recommendation to you. And then you can still go back and do IUI if you want, if let's say you don't get a good embryo or IVF doesn't work, you don't feel like doing another cycle. But I do think that IVF would make the most sense in a case like yours. However, if you felt like you want to try IUI 1 to 2 times to 3 times, you could. But having a 6-month-old, I'm thinking, let's just freeze the embryos now, maybe wait another year, and then have another baby once your 6-month-old is 18 months old. That's kind of what I would do if it were me. Okay, let's keep going. Here we go. I still have some more pages here. Okay, let's see here. I'm so lucky to get all your questions. Do you guys know that I've had over 800 questions sent in to me since I've been doing, well, actually more than 800 sent in, but I've answered over 800 questions since starting Ask the Egg Whisperer. And as you can tell, I love doing this. I could do a marathon. Actually, we should do a Guinness World, whatever, Guinness something. Okay, so here's Melissa's question. Hi, Dr. Aimee. I'm hoping you can sprinkle some sparkle in my corner. Finding your podcast has been a blessing in disguise. I'm 34 years old and just had my first appointment with a fertility specialist. I've not yet had all of the testing done. I'm waiting on my day 3 appointment, but my follicle count and AMH levels are alarming. 4 follicles, 0.09 AMH, which I believe puts me in the realm of DOR. I'm heartbroken and have yet to finish all of the testing. My husband's testing will be back soon. Am I out of hope for my very first child? Would I ever be considered an IUI or IVF patient at 34 with this kind of reserve? Otherwise, I'm incredibly healthy and active. Is there anything else I can do to increase my follicle count in the meantime? Thank you. You are easing the minds of many. The internet is a scary place. Melissa, I'm telling you, it is a scary place. So thank you for reaching out and sharing this question. Good news, you have 4 follicles. That is awesome. Okay, let's celebrate. I could start singing the song Celebrate, but I'm not going to because I'm going to have you guys just stop listening to me if I start doing that. But that's kind of what I'm, basically hearing in my head is that this is great. You're not a number. You're not an AMH. You really aren't. You're a young, healthy 34-year-old with 4 follicles. That means 4 eggs that you could have retrieved if you did an IVF cycle. That's 4 eggs. That's 4 chances at having an embryo. It might take more than 1 IVF cycle to get enough embryos for the family size that you want, but there's no better time than now to consider IVF. You are not out of the game. So think about all the things that I talk about when it comes to supporting egg quality, right? So all the supplements, it sounds like you're super healthy. And then also look at your vitamin D. Make sure you're not vitamin D deficient and start taking vitamin D now. Take it with your meal that has the most amount of fat in it for the best absorption. And then that might also help your AMH level. I've seen cases where someone's AMH is low and their vitamin D is super low. They bring their vitamin D up and the AMH goes up as well. So perhaps that's a situation that you're into. So that's why getting your vitamin D checked could potentially be helpful. The other thing is, why is this happening to you? Is it genetic? Is it autoimmune? It's so hard to know for sure. There are some simple tests that you can do though. Chromosome analysis, Fragile X screen, and then also look at some autoimmune things like anti-ovarian, anti-adrenal, and anti-thyroid antibodies. And then depending on what you learn about yourself, these tests will not take that much time. I would say go for it. I was going to say, let's get loud. I feel like that's just singing, over and over in my head. Just go in and talk to your doctor and say, please help my eggs sparkle. I want embryos that sparkle. Make this happen for me. I put all my trust in you, and please help me be a mother. And that's what I would do for you if you were here. I know you're in the UK, and I wish that you could be here. I think that's what you said, right? Are you in the UK? Maybe not. I don't know. Maybe someone was in the UK. But regardless, Melissa, I do feel like it is well worth trying and seeing a doctor and saying, let's do IVF, okay? And take my IVF class. My next IVF class is on Monday, and I can give you more advice as well. But thank you for sending such a great question. Okay, this next question is from Carrie. Carrie says, hi, Dr. Aimee. I'm 39 years old. I've been trying to conceive for 2 years. I had 2 chemical pregnancies before visiting a fertility doctor in February of 2020. My AMH is 2.6, and I responded well to medications for my first IVF cycle in August. 17 eggs were retrieved, 10 fertilized, and 4 made it to day 7. Unfortunately, 2 were abnormal, 1 high-level mosaic and 1 low-level mosaic. We decided to try again in October, but this time I did not respond very well. 7 eggs retrieved, 5 fertilized, and only 1 made it to day 7. It came back high-level mosaic. What should I do? Our doctor is optimistic about the mosaics from our first round and suggests transferring them before trying another round. After speaking to the geneticist, however, I'm not sure about the mosaics. It's all we have. What should we do? Perhaps try another clinic or transfer the mosaics? Thank you so much. I've learned so much from your show. Okay, Carrie, what's the diagnosis? We know it's egg quality. It's probably related to the fact that you're 39. there's nothing wrong with you. Ovarian aging, man, it freaking sucks. It is so unfair because 39-year-olds look like they're 25 right now because everyone's taking such good care of themselves, right? Like I don't even know how old I am. I feel like I'm 25, right? So age is just a number. But the thing is, your ovaries don't know that. Like I wish that they did. I wish I could be like, here's the Botox for your forehead and here's the Botox for your ovary and everything's going to be awesome. But at the end of the day, you're doing everything that you possibly can. The fact that you're getting this kind of transparency from your doctor is amazing and awesome. I love your doctor for encouraging you to consider the mosaics. They probably have an experience of transferring mosaics and seeing beautiful, healthy pregnancies as I have. However, it's hard to see that you've had so many, chemical pregnancies, which is two. And perhaps the reason why they turn into chemicals were because they were also abnormal. So we kind of have more information about your fertility by going through these IVF cycles. But I would say if you were a patient of mine, I would say, how would you feel about trying 1 to 2 more cycles and see what we get? And let's take a close look at your follicle count and not start a cycle unless we really felt that we can get at least 10 eggs. Given the fact that your AMH is 2.6 and your cycle in August was just recent and you got 17 eggs, it would make sense perhaps to check your AMH again and see if it's the same. Maybe it doesn't make sense to keep waiting. And try all the egg quality stuff that I often talk about, like the NAD, the pterostilbene, the CoQ10, the HGH. Make sure you're on a good prenatal vitamin with fish oil and vitamin D. Look at the sperm quality closely. Make sure it also sparkles. And I would say if you're comfortable trying again, I would try again. One other thing to consider doing, talk to your doctor about whether every lab is different. Just because I'm bringing up this technology doesn't mean that it's something that you should also do or it would help you. But just asking the question just makes you feel like you're empowering yourself, that you're advocating for yourself. So perhaps ask your doctor about doing a sperm DNA fragmentation test and then see if calcium activation could potentially help in your case. So talk to your doctor about that. Maybe they have a perspective. And if the sperm isn't good, maybe there are things that you can do to improve it, like adding technology like Zymot or adding Pixie, for example. So there are a few other things that you might want to consider doing if you want to do another IVF cycle. However, if you're going to do a transfer of mosaic embryos, it is hard. And the reason why it's hard is these embryos could be totally beautiful and you go into it with so much hope in your heart. And you have to be prepared for the possibility that it might not work, and even worse. And I've unfortunately had these experiences with my patients because I really want to give every possible embryo a chance that could turn into a healthy pregnancy. But having a mosaic turn into a miscarriage is something that I've experienced, and it's just the darn worst, And so if you're not prepared for that, meaning if you don't feel like that's something that you want to deal with right now, then and who wants to deal with that, And I know you've already had the biochemicals, but it might make sense to do 1 or 2 more cycles before you start considering transferring a mosaic. Because if you end up with a miscarriage with a mosaic embryo, that could set you back probably maybe even 4 to 6 months, depending on at what stage the pregnancy stopped growing. Okay, guys. Last page. Here are 2 more questions. This question is from Jennifer. And Jennifer says, hi, Dr. Aimee. I have a question about a shy ovary on my past 2 ultrasounds, one last week and one about 6 months ago. The doctor had a hard time finding my right ovary. At the first office visit, she was able to find it finally, but at my new clinic, the doctor sort of gave up and said it wasn't important at the moment. It was an initial appointment. He did mention that this could be contributing to my low AMH. It's gone from 0.78 to 0.32 in the past 6 months. And I'm worried that after stimulation, if he can't reach the ovary, he may not be able to retrieve any eggs that may be there. So my question is this, is there anything I can do about this to get my ovary to a better position? Also, can you think of any reason my AMH may have fallen so fast? It was 0.78 in May of 2019, 0.77 in June of 2020, and then bang, 0.3 in January of 2021. I'm 39. Thank you so much for all you do. I've learned so much and I've been so encouraged listening to your show. Jennifer, I would say you're normal. That rate of change, 0.7 to 0.3 in a matter of May of 2019 to January of 2021 is normal. That's normal stuff. So this is what being 39 is. And that happens once we're, let's say, around 37, that you can see the AMH rate of change fall faster than for someone, let's say, going from 27 to 29. right? We see a pretty constant level of AMH at that age, but we do see changes that are pretty, not rapid, but sometimes can feel rather dramatic when they're actually quite normal. So you still have a chance of pregnancy. I would say that the fact that they are having a hard time getting to your right ovary might be just because you have most of the follicles on the left side and the ovary is pretty quiet. So sometimes you can have no follicles on one side and 3 follicles on the other side. And that's why it might look like that ovary is being shy. And that's not unusual at all. So one thing to ask your doctor, okay? So Jennifer, ask your doctor if it makes sense to watch you more closely during your IVF cycle to see if doing a random start would make sense for you. Not necessarily random, but you could do a luteal phase stimulation. And, you know, I come up with these different ideas and thoughts and ways to describe things to people. And one of them is, you know, you're standing in the sand at the beach and you're looking out at the waves and you're watching these waves come in. And if you, I don't surf, I just help people have babies. I don't know anything about surfing. So for anyone who surfs out there and you're listening to me and you're just like, she has no idea what she's talking about, it's true. I don't when it comes to surfing. But, you know, I think of eggs as these waves that come in. And if you're a surfer, you're like, okay, I can see that that's going to be a good wave for me to ride out there. And that's how I think of eggs and follicles. So when I monitor people really closely. I'm like, come in. Okay, not this month. Because I take care of a lot of people with an AMH like yours. And I enjoy it. I think it's fun. It's challenging. Don't get me wrong. But when it works, man, it feels so good. And then, you know, I'll see a wave and then I'll be like, this is the wave that we're going to ride. You know, I've been watching really closely. It looks like this set of eggs looks the best because the egg count is a little bit higher than we've seen in the past 2 to 6 weeks or so. And then we take that wave and hopefully take it to the end and don't crash into the sand. I know that sounds very dramatic, but what I do is pretty dramatic, right? I mean, okay. This next question is from Tamika. I am 40 years old. I have 2 large cystic masses in the lower pelvis. I'm told both ovaries have to be removed along with the cysts. Would egg freezing be an option for me? Also, I think I have HOPE syndrome. So what Tamika is referring to is PCOS. So PCOS means having lots of little tiny cysts in the ovaries, okay? And those are called follicles. About 12 or more per ovary will give you the diagnosis of PCOS. Along with that comes having high androgen levels or signs of high testosterone, like, you know, hair above your lip, upper abdomen, also having, let's say, temporal balding, so hair loss here, having problems with acne, like here and here. I'm demonstrating it very well today. That's what we call maskne. And then also maybe having some problems with body size. Not everybody has problems with maintaining their weight, but sometimes having PCOS can cause metabolic issues. So the 2 large cystic masses in your pelvis could obviously take away your chance to have a biological child, but just wait. What I would say is this: ask your doctor, what is my AMH level? Okay, let's find that out first. If they feel like it is safe for you to go through an egg retrieval procedure given the cyst, then I would say I would do that. However, if there's any concern at all that the cyst could be related to, let's say, a non-benign process, then it might make sense to just go right to removal of the cyst and then finding a different way to be a mother, right? So I'm hopeful that your surgery will go very, very smoothly and the pathology will come back extremely benign. But if not, find a fertility doctor that will find a way to help you preserve your fertility, especially if you have HOPE syndrome. If you're 40, it could be a blessing in that you might still have good ovarian reserve so that you still have eggs to fertilize, and maybe consider even making embryos rather than just freezing eggs. Okay, guys, that's it for my sent-in questions from you guys from Ask the Egg Whisperer. So I'm just going to scroll through these questions and I'll try to get through them as fast as I can. Here we go. Thank you guys for live chatting with me tonight. Allie says, hi, Dr. Aimee. Thanks for all you do. Question, what is the ideal IUI timing post-trigger, 24 or 36 hours? I've heard that likelihood of pregnancy is higher if there's intercourse one day before. So I always give my prescription for sex the night before the trigger shot. So if you were due to come in for a follicle check and possible trigger shot, I tell my patients to have sex the night before. I make the decision about when to do the IUI based on what I see, like how sparkly are the eggs, what is the size, what does the lining look like. All those parameters go into my decision-making process as to when the best IUI window will be. I want the eggs and sperm to be together at the exact same time. So I can kind of predict based on what I'm seeing as to when that time is going to be. Your doctor can too. That's what being a fertility doctor is all about, right? There isn't a number. It isn't like 24 or 32 or 36 or 48, right? It's all about the whole picture and what we can do to maximize chances for our patients. Next question is, for how many weeks after an FET should you keep checking HCG levels? So once I see a pregnancy inside the uterus, I almost never check HCG levels because I can tell that the HCG is going to be high. However, if I have a concern that maybe the pregnancy isn't viable or have some other concerns, then I do sometimes check the HCG, but very, very rarely do I check. Next question is, for IUI, what's the ideal follicle size for trigger? Going for superovulation, my follicles are 19, 16, and 12. Can we wait a day or two to allow the smallest one to catch up? I'm 37. So I like to trigger at 20 to 22. In a case like yours, I would have you come back tomorrow and see how they look to decide if whether we should trigger tomorrow or on Saturday. That's what I would do. Next question is from Ann Tran. Dr. Aimee, I'm 40, have a low AMH, 0.5, and an FSH of 7, AFC of 6. After 2 unsuccessful rounds of IVF, currently on round 3, I'm thinking about trying mini on it as a different approach. Thoughts? I would absolutely consider mini because based on your AMH, it looks like you would probably be getting around 5 mature eggs. So having that approach can hopefully help you get all 5 as mature eggs without using standard doses. So it might be better for your eggs. Who knows? It's worth trying. Okay, next question is from Sheila. Hi, Dr. Aimee, general question, but what are the chances of miscarriage after a heartbeat? At 8 weeks of pregnancy, 166 beats per minute, we didn't test our embryos at 34 years old, and I'm worried as I've had a miscarriage before. I can totally understand why you would worry. We're always going to worry. I mean, how can you not, especially when you've had a miscarriage? So the likelihood at 8 weeks, if you've already had a heartbeat and you're 34 years old, is really, really low. We're talking about less than 5%. So consider doing the NIPT test. That's the non-invasive prenatal diagnostic test that you can do after 9 weeks of pregnancy that can tell you more about the genetics of your pregnancy and hopefully will give you more reassurance. And if you are super worried, go back to your doctor in 2 weeks for another ultrasound as well. So next question is, do you stop supplements during STEM or can you continue CoQ10 and NAD? I ask my patients to continue. Listen to your doctor though, folks. Not every doctor is the same. Nicole is asking, can you review, someone's asking me to review a powder, and I would have to Google it, and I'm not going to go on my computer right now. Hi, Dr. Aimee. First FET, hours later, I had an allergic reaction. Eye swelling and wheezing, miscarried a PGS normal embryo. Second FET, same reaction. Could it be embryo glue, or is my body attacking the embryo? Alda, I would say it would make total sense to do some allergy testing and look really closely at all the medications you're taking on that day. Is it related to a steroid? Is it related to aspirin? Is it related to Valium? I don't know what it is, but whatever it is, we need to stop it. And maybe even do a sham transfer. Like this is a situation where I'm like, let's do a mock cycle and see if it happens on the day that we're faking it, right? Like you just put a catheter in, don't put an embryo in and see what happens. Maybe it could be severe stress that's causing it. Sometimes people get these kinds of reactions under extremely stressful situations. And maybe taking a Valium would help if your doctor didn't already offer you that. Next question is, hi, Dr. A. Retrieval had 18 eggs today, 28th year, no medical issues, unexplained. Is that a good number? Of course it's a good number. That's fantastic. Someone's asking, do you use an antihistamine protocol? Is it effective to use Claritin and Benadryl during the FET? I don't use it as a standard protocol. I have used it in certain cases, but it isn't something that I apply to every case. But in someone who has allergic tendencies, like an allergy and like what you described, it would make sense to ask them to take Zyrtec on the morning of their transfer. Okay, someone is asking, if you get COVID right after a transfer, can it affect the embryo? And the answer is probably not. The only possible way I think it could affect an embryo is if you get a really high fever, you're coughing nonstop, you're not able to sleep at night. That could all combined, having trouble, like the severe stress and effect of COVID on your body could potentially decrease implantation rates. Otherwise, just having a positive test in most cases won't cause any harm to you or your pregnancy. Someone's saying, what are your thoughts on embryo grading? My thoughts are it matters, right? When you go into a diamond store, every diamond has a different price, just like embryos. Every embryo quality has a different implantation rate associated with it. Quality matters. But if you have a bad quality embryo that implants, there's a really good chance that that pregnancy is going to be healthy and the quality doesn't matter anymore. Next question is, let's see here. When would you decide to do a laparoscopy to check for endometriosis if you have silent symptoms? So if you have symptoms of endometriosis, we don't call those silent symptoms, but I would decide to do a laparoscopy for endometriosis if someone has symptoms, if they've tried transfers before that didn't work, if they had a positive BCL6 test, then I do think it makes sense to do a laparoscopy. Next question is, why is a day 6 blast considered not good in comparison to a day 5? A day 6 is not considered not good. A day 6 can be just like as good, almost as good as a day 5. Think of a kernel of popcorn. The popcorn comes out of the kernel at a different rate. And if you look at a popcorn and if someone showed you, how about this? If someone showed you a kernel of popcorn that became, if someone showed you 2 popcorns, they would look the same if they were the same, right? And so day 5 and day 6, if the embryo is beautiful on day 5, and then also you have a beautiful embryo on day 6, the pregnancy rate is like, rate of change is like, the difference is so small. So ask your lab though, because every lab is different. So the labs that I use, the difference in pregnancy rate is very small between day 5 and day 6. And there are some labs that don't find that there is a difference between day 5 and day 6. Okay, guys, I am out of water now. So that's my rule. When I'm out of water, I got to go home. So thank you guys for sending in your questions to Ask the Egg Whisperer. Thank you for live chatting your questions. And I hope to see you guys all in my IVF class next Monday. It's a party. I promise you. We do get loud and we talk about sparkling eggs, sparkling sperm. We didn't talk much about sparkling sperm tonight and sparkling embryos. So I hope you guys have a wonderful night. And I can't wait to see you guys again really soon. Okay, have a great one. I'll see you guys later. Bye-bye.